Hi, hello.
Hi, Clara. Hi, Sebastian. Thanks very much.
Hello. Was also working on a few of the ITs. How's everyone doing?
Hey, everyone.
Perfect. Let's see.
Hello.
Laurita, hello.
Everyone.
Good. I'm going to switch devices just to be able to talk to everyone better. I'll be right back.
Don't see Thekla. Is there Thekla?
Što se večeras dogodilo s atmosferom? Ja se isto pitam, ja sam probala na sve načine. Možda su čuli da ciljate na pobjedu, pa vas bojkotiraju. Pa nekim bude, jer bi sad vi bili za to i mislim da će...
So Clara, nice to see you. Let's see who else is here.
Hi, Camilo.
And I know, lovely seeing you. And I know Laura
Me
is
too.
here. And Mary Louise is here. And so I've seen Sebastian.
Hi, Camilo. Hi, everyone. Nice to be
Hi.
here.
I know Mike is... Mike, there is he is. We were texting. Thank you to Tekla if she's in the audience. And to Tosha. Is Tekla, can anybody see Tekla? Because she emailed saying she was in the...
I'll just email her again.
See her.
Which link?
Perfect. I can send... Let me send her an email just to make sure she's in the correct waiting room.
Yeah.
About that. I'll keep it to everyone in the same thread so that we all in the thing. What? Okay, the yours for mine will take hold, I'm sure, Mary. Thank you.
Hey, Camilo, can you hear me?
Yes, I can hear you.
Okay, I was having troubles with my phone.
I think we're just waiting for Tekla, which is
Nice.
probably just in a parallel reading room in a parallel universe.
Okay, nice. Perfect.
But we've given her links that work, so I think it's probably in the process. But in the meantime, hello to everyone from all over the world. Hello to our awesome speakers and moderators that have accepted to join us. And it's awesome to see all these folks that have registered for the webinar. As you all know, and you're getting notifications. The webinars are recorded and they're shared both on the website of the WFPI and ISMRM. So we periodically check the attendance and the utilization of these resources, and it's always much, much larger than you see. So thank you to all of you for the efforts that you put into it. It's very far-reaching and lasting in time. So thank you very much for that. With that in mind, I'm going to say let's give it 5 more minutes. It's just we typically start a few minutes after. That allows us to get more people to get their coffee, lunch, dinner, whatever it is, and land into the link of the webinar. And it will also give us time to rescue Tekla, who's in the cyberspace. So I'm going to mute myself and give it just a few more turns for the clock while we figure these things out. But it's great seeing everyone. Welcome, Tekla. I see you have joined us and found us in the right wavelength. So we were saying that we were just waiting for a couple of seconds. Thank you so much. We typically start a few minutes after just to allow people to refill their coffee, tune in the appropriate way. But it's great to see you, and thank you for taking the extra effort of finding us in the right wavelength.
Yep, just have to adjust my camera a little bit. So
Thanks very much, Tekla. We know it's the evening for you, so after a long day. So thank you very much. Really appreciate it. Nice to see you.
nice to see you too.
That's Brisbane, by the way, in case anyone's interested. That's in 2011. So it was standing on the roof of a building my apartment's in, and that is where the 2032 Olympic Games are going to be. So I'm just looking out of the way so you can see this is the windy river that goes through the middle of the city. And so you can see it's pretty green, mango trees, palm trees, bougainvillea, a few gum trees.
Are the Olympics paying you for this or is it non-paid advertisement that you're doing for them?
They keep changing where they're going to put the venues, but anyway, so that's a little sneak peek if anyone's interested in heading there in 8 years' time. Whether or not there'll be venues remains to be seen. But the food's good and the beaches are great.
Well, that's
Looks
wonderful. Well,
yeah.
as I was saying, so now I think we have the crew complete. So thank you, everyone, particularly the speakers and the moderators. We're very excited to have all these attendees waiting for us. So I would say, without further ado, today, Sebastian and Laura are going to be helping us moderate this outstanding webinar, and I'm going to let them introduce themselves, introduce the speakers, and we can get started informed. They're going to just tell you a couple of things. This is very informal, so they'll just do a couple of housekeeping items and reminders in the beginning. And thank you very much to all of you. I'll let the podium for our two moderators.
Camilo. Hi, everyone. Hi, Tekla. Camilo.
Yes, ma'am.
I would like to ask you how long should be the introduction of Tekla for me? How many seconds, minutes? Because there are lots of things to say.
That's always a good problem to have, and we're very grateful. I would say I leave it to you. And one of the advantages of having people that are so established is the introductions often are not needed. Many of us know Tekla's work, so I would say give it a couple of minutes, like 30 seconds to a minute. And for all of those, if you can keep mind of your microphones and be muted unless you're the speaking panelist, that'd be awesome.
Yes, I will say to please turn off the microphones and that the questions should be entered into the chat and that the session are recorded. That this is
perfect.
The three rules. Okay?
Yes. Yeah, let's get started. So good luck.
Wonderful. Thank you, Camilo. Okay, Laura, do you want to start?
Okay. Okay. Hello, everyone. It's a great pleasure for me and honor to moderate this webinar that is organized by the International Society for MR Radiographers and Technologists, together with the World Federation of Pediatric Imaging. My name is Laura Tanturri de Orazio. I work as a consultant pediatric radiologist at Bambino Gesù Children's Hospital in Rome, in Italy. I've been actively involved in the European Society of Pediatric Radiology since 2014, and I am now the chair of the Musculoskeletal Task Force since last year. I am moderating on behalf of the World Federation of Pediatric Imaging. And Sebastian Gallo is moderating on behalf of the International Society for MR Radiographers and Technologists. So I ask you please to turn off the microphones, and I remember that the questions will be entered into the chat, and sessions are recorded and will be later uploaded on both websites. So it's a great pleasure for me to introduce Tekla Boncalle. Tekla is the head of the Department of Radiology of the Olga Hospital Clinical in Stuttgart. She's one of the that is one of the Germany's largest children's hospitals. She's an associate professor at the medical faculty of the University of Tübingen, and she's a renowned expert in pediatric musculoskeletal radiology and imaging in pediatric oncology. And she has published a lot of scientific articles and book chapters. She is the reference radiologist for the International Oncology Study Groups and CWS, and her special interests include the whole body MRI, dynamic contrast enhanced MRI, ENT imaging. So she is also a member of the editorial board of Pediatric Radiologists, and she's a regular reviewer for several journals on radiology and rheumatology. So please, Tekla, start with your talk today.
Yes, thank you, Laura, and thank you for this very, very kind introduction. Yes, my talk today is a little bit about MRI technique, and I think I have to share my screen now.
Tekla, it should be down the bottom center. There'll be a green arrow. If you go to the bottom.
I'm not allowed to share my screen. Someone please should give me the right to do this.
You should be able to share now. I apologize.
Thank you.
I think this is it. Can you see my presentation now?
Yes,
we can
see it clearly.
That's it. So my talk is on some technical aspects of the MRI, and I've called it Mind the Coils because I think coils are very obvious and they are always there, and sometimes we forget how important they are. So I have no conflicts of interest, and I myself like to look at the MRI as a giant toolbox. And it's a really huge one, and so I can only present you some selected highlights today. And this will be about the hardware, as I said, about the coils and about coil positioning, some aspects of software and sequences, orientation of sequences, of slices, and of course, what do we do with metal devices in the image area. And what I always like to point out is the usefulness of DWI. Also, contrast enhancement, some we should not forget. And the most important message for me is that we have to think that MRI is highly operator dependent. We always say that sonography is... sorry, could you please mute your microphones? MRI is highly operator dependent. We always talk about ultrasound to be operator dependent, but I'll show you that MRI is as well dependent on us. This is a recent example. This is an infant, a newborn with a neuroblastoma, and the image on the left is the one during the first week, and the image on the right is the one we did after the child was transferred to our hospital. Both MRIs were done with the same type of machine, the same vendor, and it was a 1.5 Tesla machine. Both sequences are stir images. You won't believe it, but both images are supposed to be stir images. And you see on the left side, there's a problem with the positioning of the child. This is the best image you could get to have a view at the arms. And you see there is no fat saturation. The stir image should have the fat saturated, and this didn't work somehow. And if you look at the field of view and the matrix, you see that the spatial resolution is much lower than in this image, and same machine, same vendor, same type of machine. The coils, the radio frequency coils, we all know them, we all see them every day, and we know that they receive the MRI signal, and some of them even transmit the RF field. And they determine our image quality. They have a high impact on the signal-to-noise ratio, and with this on the image resolution. And the rule of thumb is that the receive sensitivity is lower in larger coils. It's higher in a small coil. But however, the signal uniformity is better in a large coil. And coil designs enable acceleration techniques like the phased array coil you see on the left side, which is combined of several, in this case, 4 smaller coil elements, and the combination of these elements allows, for example, parallel imaging. Coil positioning and coil selection is highly important. If you look at this stir image of the foot, you see that there is something wrong at the heel. There is a high signal-to-noise ratio, and the image is rather dark. So maybe this coil element wasn't selected, or the patient has moved away from the coil. We don't know, but we have to check if we see an image like this. The same in this image, a patient with an osteosarcoma, the distal femur, and you see there is quite a bright signal at the front in both of the sequences, but there is a dark area over here with a high or a low signal-to-noise ratio, a high level of noise here. So maybe there is a defect in the coil, maybe the coil has not been adjusted properly. So we have to check this. Signal uniformity again. Patients with osteosarcomas often have pain and they are not able to stretch their legs. And the result is that this gradient echo sequence in this rather inhomogeneous magnetic field has no fat saturation. As you see here, there is some fat saturation here, but not at the dye. So we have to check this and try to readjust the coil, try to reposition the patient. Shimming helps. There is a special coil which, if you select it, corrects or tries to select the magnetic field. And there are other correction techniques in the post-processing with names like clear, pre-scan normalize, or pure. This depends on the vendor. So don't forget to use all these techniques to get a homogeneous image. This is quite an old examination, a 3-month-old girl with a rhabdomyosarcoma in her left palm, and you see the tumor here around the tendon of the thumb, and you see it here in the carpal tunnel, the contrast enhancement of the tumor. And you see a very high spatial resolution, a low or a high signal to noise ratio, a low noise. And this was a 1.5 Tesla machine and a ring coil. So you don't need a 3 Tesla machine to get very high resolution images. But as you see with a ring coil here in the palm, you see there is a drop of signal to the back of the hand. And this is, of course, a disadvantage. With a coil like this and a higher magnetic field, you're able to get more homogeneous images, like in this child with a JIA and a tenosynovitis here in the carpal tunnel. These are just examples. So don't forget to adjust your coils and be critical about the signal to noise ratio of your images. Let's move on to the choice of sequences, the slice thickness, orientation, and then a little bit about metal artifacts and DWI. This is a simple diagnosis, radiograph, of course, of a spondylolysis. To see a spondylolysis on MRI is sometimes difficult. You may see it like here in this image if you happen to have your image orientated at the part of the vertebra. But if you don't, you won't see the spondylolysis because it is so small. What you can do is do 3D images with thin slices like this death sequence with 1 millimeter slice thickness, and then readjust your image so that you even can see the little Scotty dog you know from the radiographs here on the MRI. So don't forget to use the 3D reconstruction in such cases. This, however, also helps in conventional imaging. This is an interesting article on the reconstruction, multiplanar reconstructions of standard 2D turbospin echo MR images. This is one of our patients, and we did a T2, 2 millimeters in the axial plane. And if you want to look at the ligaments of the foot, it's often difficult in these axial planes. But if you adjust your slice in the post-processing in the 3D tool, you may easily see the talofibular ligament, the anterior talofibular ligament, or this part, for example, of the medial ligament. So this is easy to do. Just think of it and don't forget it. Metal artifacts. Often a big problem in patients after tumor surgery. You see on the radiograph, there is a lot of metal in this leg, and MRIs don't look very beautiful, but you can do or you can choose a lot of issues to try to reduce these artifacts. We know that they are more pronounced in radio echo sequences, so prefer the spin echo sequences. They are highly disturbing in DWI, so this doesn't work with metal, and they are pronounced in sequences with spectral fat saturation. So we should use other methods of fat saturation, which we need, of course, after contrast injection. So spin echo sequences, stir sequence, or also a spin echo sequence would work, and try to use subtraction analysis instead of fat saturation. So if you do the exact the exactly same sequence before and after contrast enhancement, you may subtract the data and have a nice fat saturation and nicely see the contrast enhancement. And there are dedicated sequences. The vendors try to improve their sequences. My experience with those sequences is not as good as with these more classical approaches. Yes, and diffusion weighted imaging. We all know that the loss of signal intensity from the random microscopic motion of water is what we call diffusion imaging. And there are sequences with sensitive gradients, with gradients which are sensitive to this diffusion. And highly important is the apparent diffusion coefficients, with this calculated from at least two sequences with two different B values. The B value is a measure of the diffusion of water. We have, as we know, unrestricted diffusion in water itself, in spinal fluid, in the bladder, and in cysts, for example. And we have a restricted diffusion in cell-rich or structured tissue. We all want or would want that this always shows that this is a malignant tissue, but of course we know that it doesn't, because lymph nodes, normal lymph nodes, have a lot of cells as well, and they show restricted diffusion. The ovaries, a dermal cyst as well, and abscesses, as we know. But it sometimes helps to differentiate or to discuss if this might be a cell-rich, maybe malignant tumor or not. But also red bone marrow, of course, may have a diffusion restriction. Under chemotherapy, or before and after chemotherapy, however, diffusion-weighted imaging is really helpful because it is a predictive biomarker for acute cytotoxic effects. It correlates with the apoptosis of all these cells which cause the diffusion restriction in the beginning and before chemotherapy. And the increasing ADC values show the tumor response to the chemotherapy. This is important, and this is important to think about before the chemotherapy starts, because we need these images from the beginning. This is an example of an osteosarcoma, and you see before chemotherapy here in the proximal humerus, there is diffusion restriction here, the image with the B1000 value here, the ADC map. This is just a color map of the ADC values, and you see after chemotherapy the diffusion restriction disappeared and the ADC values increase. You also can show the distribution of the ADC values, like in this osteosarcoma of the leg, and you see that there is a distribution before the chemotherapy and after chemotherapy, and the distribution of the ADC values shifts to the right, that is to higher ADC values. And this also shows, in this case, a good tumor response to chemotherapy. It has been shown that in osteosarcomas, the ADC values may predict the tumor response, but more important is the ADC ratio from calculated from the ADC values before chemotherapy and after chemotherapy. And this is the message I want to send, is that we always need the DWI images before chemotherapy. And this is much more valuable than only having the ADC values afterwards. There are a lot of questions still to be discussed and still to be answered. We still do not know the optimal B values for different tumors, and we don't know where to measure in all solid tumor parts. Do we want to measure the maximum ADC values, the mean ADC values, or which is most logical, the minimum ADC values? And is there a ratio and a cutoff to say this is a good responder or a poor responder? These are all open questions, but nevertheless, in routine imaging, DWI may be helpful. But of course, it also has its limitations and its disadvantages. This was a case of a Ewing sarcoma, and this is the image after chemotherapy. And we still see a part with high diffusion restriction here and low ADC values here. And it looks like that there is still a tissue enhancement, contrast enhancement, but if we do the subtraction image, we see that there is no enhancement. This was a hematoma after the biopsy, and there was still a bright T1 signal before contrast injection. And so this is what you see in the subtraction analysis. Don't forget to use it and don't misinterpret high signals in T1. Yeah, coming to contrast enhancement, there is more about it than just morphology. And it's very important for many of the examinations to realize that it is not static. We always or mainly use contrast enhancement in a yes or no decision, but we know that it is not static, that it is dynamic. This is already a routine approach in the multiparametric MRI of breast and prostate tumors, but you also may consider this for MSK disorders, for example, in inflammation, JIA, osteomyelitis, and of course in tumors. And contrast enhancement and changes in enhancement in the dynamic also show the response to chemotherapy. But let's have a look at a benign issue. This is a normal temporal. This is a temporal mandibular joint. And if you look at the timing, and if you look at the first 5 minutes, 1, 3, 5 minutes of contrast enhancement, and you measure it over the time, you see the red line here that there is increasing contrast enhancement in the synovium of the temporomandibular joint. And you may imagine that it is a difference if you look at the beginning of this contrast enhancement or at the end to measure or just to assess contrast enhancement in this joint. And this is true for all synovial joints. It's just an example. And if you look at this publication by Rita et al., they showed that it is highly important in the assessment of the wrist joints and in JIA patients. Another example where we may use the dynamic contrast enhancement is this one: an adolescent with hip pain on the left side. And you may, from the STIR image, already guess that this might be an osteoid osteoma. But after contrast injection in the late phase, you don't see anything of the nidus. However, in the early image, you see that there is a huge contrast enhancement in the nidus, and this graph shows you why. It shows that there is an early enhancement in the nidus and a very slow enhancement in the edema. And if you look at this point where there is a huge difference between both tissues, you will see the nidus. If you look in the late phase, you won't see the nidus. So if you say this was easy, I would have seen the nidus without contrast enhancement. Anyhow, look at this patient. This was a 15-year-old boy. He was seeking help because of behavioral problems, but he had also had pain in his back. So he got several MRIs, and in one of these MRIs, there was an edema here. Couldn't see anything else. You couldn't see the reason. But if we looked at our early phase of the dynamic contrast enhancement, we suddenly could see the nidus of this osteoma, which caused most of his problems. So sometimes this is really helpful. And when we knew the nidus, when we knew where it was, we also could see it in the other images. Same in osteosarcoma before chemotherapy and after. You see how the dynamic curves change under chemotherapy. So always worthwhile to have a look at it. You may measure all the different values in these contrast enhancing curves, the time to peak, the washout, and so on. Or you may just look at the shape of the time intensity curve, which always gives you a good impression of what is happening in this tissue. If you want to, if you like to know more about it, this is one of the publications I can recommend. Of course, there are limitations to this contrast enhancing dynamics. They are influenced by the environment. They are influenced by the length of your bolus and many other parameters. But just looking at the shape of the curves helps a lot. As we already know, as I already said, from breast cancer and prostate cancer. And don't forget that there is this nice tool of subtraction analysis, which helps a lot, for example, in patients with several joints involved in a JIA. As in this case, if we do a subtraction analysis, we have a nice overview of all these joints which were involved. However, there are new sequences, new techniques coming up, and we have these first publications on T2 flare fat set images in arthritis in large joints. And it seems that these flare images like this one on the right have just the same information as T1 images after gadolinium. So this may be the future, especially for large joints, and this may replace the use of contrast enhancement. And there is, of course, more to come. We have a lot of new sequences or newer techniques, and of course, we have AI to improve the assessment. My take-home points to you today will be that MRI is highly operator dependent, and we should know our MRI toolbox to improve our image quality. We can learn or may learn from and learn together with our technologists, which is always very helpful. Don't forget that contrast enhancement is not static, and know your interval, your delay from the injection to your sequence. And of course, quantitative imaging is helpful to assess chemotherapy response, but don't forget that you always need the sequence before the start of chemotherapy. Thank you for your attention.
Thank you, Tekla, for your excellent talk on MRI hardware and the importance of coil function in image quality. It was very insightful. Before we move on, I would like to ask you if you have any recommendations for coil selection. We're working with ultra low or ultra high like strength fields. Are there any specific considerations or tip you would suggest for coil optimization or coil selection in these settings?
I'm not quite sure if I understood your question. You mean that the magnetic field is the question is about the
Yes. So basically, coil selection when you are using ultra low fields, meaning like less than 1.5 Tesla, or when you are using like ultra high magnetic fields like 70.
Yeah. Of course, each MRI has its own coils, and you normally can't exchange these coils between different field strengths. And it's just very important to know your coils, just to try and to find the best solution for your scanner and for your set of coils. This is what I think is the most important. I do not think that there is a general recommendation how to use these coils. Especially for children, there is not such a large variety of coils, and you have to be creative and flexible and try to use what you have and try to use it for the best of the choices. For example, use your head coil for feet of little children, which is very helpful. Things like that.
Excellent. Thank you so much. Okay, so moving on, let me introduce myself. I'm Sebastian Gallo, and I'm moderating on behalf of the International Society for Magnetic Resonance in Medicine. I'm a current radiology resident at the Massachusetts General Hospital and Harvard Medical School. I have had the privilege of working as a researcher in the Pediatric Imaging Research Center at the Massachusetts General Hospital, where basically I have focused on advancing imaging techniques. I'm also actively involved in both the ISMRM and the SPR, and I'm excited to be here to share insights and discussions on the latest advancement in our field. And again, thank you so much for joining. Now, introducing our next speaker, it is my pleasure to introduce Dr. Maria Clara Anoni. Dr. Anoni is an esteemed pediatric radiologist from Argentina, specializing in MSK radiology. She works at the Department of Radiology at the Garrahan Hospital, one of the largest pediatric hospitals in Argentina. And she also practiced at Gandolfo Hospital, where she also serves as a pediatric radiology attending. Dr. Anoni is recognized for her expertise in pediatric musculoskeletal imaging and is frequently invited as a speaker at national and international radiology conferences. She is an active member of several prominent professional organizations, including the Argentine Radiological Society, the Argentine Pediatric Radiology Society, and the Argentine Pediatric Society. Again, we are thrilled to have her with us today. And Dr. Anoni, the microphone is yours.
Thank you very much. Hi, everyone. Let me share the screen. Well, thank you very much again, and it's an honor for me to participate in this webinar. Now I am going to talk about physical alteration in the immature skeleton. I have no disclosure. These are the topics that I will speak about: overview of normal growth, direct and indirect lesion mechanism, trauma and complication, scurvy and rickets, vascular alteration, infection, alteration due to radiotherapy, and tumors. Firstly, I want to show you the phases. We really need to understand what happened in each area. We know that the bone formation is in long bones develops by mean on endochondral growth. The resting zone here is the closest zone to the epiphysis, which houses the germinal matrix and active chondroblast. The important thing is here is where the blood supply flow into the resting zone. Then we have the proliferative zone, which contains active chondroblast and synthesized extracellular matrix proteins. The cells began to grow and form columns. The hypertrophic zone is the area of maturation where cells really hypertrophy, and this growth affects their vascularization, resulting in cells death. And finally, we have the calcification zone. It's the level where cartilage calcifies and becomes bone. It is the primary spongiosa where vascular invasion occurs here. And the longitudinal skeletal growth, the next one, the longitudinal skeletal growth occurs, as we said, through endochondral ossification, which involves the formation of bone on a cartilage template. During the process, a primary ossification center is formed within the diaphysis and a secondary center within the epiphysis. And this center, the secondary center, separates the epiphysis into articular cartilage and the growth plates and protects chondrocytes from mechanical stress. Here we can see images of knees in sagittal T1 at different ages. The thickness of the primary growth plate stay constant during development. At the onset of the skeletal maturation, the growth plates narrow and finally closes, as in this image of a 15-year-old, but it can leave behind a temporary scar. The epiphyses are initially cartilaginous and gradually replaced by enlarging secondary center of ossification until only the articular cartilage remain. Well, the factors that modify growth, in addition to genetic factors, are nutritional, endocrine, activity levels, and blood supply. And any alteration on this factor will modify normal physical growth. And it is interesting to know that the physis responds with a limited number of reactions to a large number of processes. This reaction, These reactions are increase, decrease, or abnormal growth, depending on whether they are generated by systemic or local disease. These are different causal mechanisms of lesion, and they are stereotypical imaging finding. In the case of direct insults, we can see bone breach or delayed capping deformities because transphysial vascularity facilitates recruitment of osteoprogenitor cells. In indirect lesion, we have fragmentation of secondary ossification center with a slow longitudinal growth, focal breach, and diffuse band of repetitive microtrauma at focal tongue. In this case, metaphyseal vascular compromise disrupts endochondral ossification, allowing chondrocytes to extend into the metaphysis. Moving to the mechanism of lesions, here we can see different Salter-Harris fractures, which are subtle in radiograph. In this case, CT can help us to assess the fracture, as in these cases. We know that Salter-Harris classification is simple and very descriptive in structure, but is important to assess the potential transphyseal vascularity. As another example, of direct lesion, the slipped capital femoral epiphysis, SCIFI, is the most common cause of hip disease in obese adolescents. It's more frequent, more common in boys, and can be bilateral in almost 40% of cases. The fracture plans often involves the proliferative and hypertrophic zone, and this can be due to a combination of mechanical stress and hormonal imbalance. With AP and frog leg position, we can assess bilateral injuries. This dotted yellow line marks the Klein line, which evaluates the alignment of the epiphysis with respect to the femoral metaphysis. The early evidence to the SCIFI, on MR, is a diffuse physial widening, as we can see here with red arrow, and in the sagittal proton density image of the right hip, the peak posterior rotation of the femoral head epiphysis axis in blue line, and relative to the femoral neck axis in red line, indicated retroversion. And this is an example of Salter-Harris type 1 fracture. In case of indirect lesion mechanisms, the soft tissue interposition into the growth plates is uncommon. However, it is important to recognize because open surgical reduction will be required in these cases. Soft tissue interposition should be suspected when the widening persistent after post-reduction radiograph, and show this widening more than 3 millimeters. In this image, we can see the persistent widening, and in T1 and T2 fat SAT, we said in another patient soft tissue interposition in the fibula. The metaphyseal periosteum is the most common soft tissue interposition in this case. Moving to different insults to the physis can lead to physeal bridge formation. Physeal arrest in this case can be either complete or partial. When they are partial, can be classified based or their anatomical location as a central surrounding by a normal physis, and can cause leg discrepancy, peripheral, which can cause angulation and shortening, and peripheral and linear, surrounding by a normal physis. In this radiograph, we can see a central bridge bone and widening the radiometaphysis, and in this MRI, we can see the bone bridge surrounding by marrow bone edema. Well, this entity is a focal periphyseal edema region of marrow edema seen on MRI and located at the physis. They are thought to represent potentially painful manifestation of physiologic physeal fusion. In this coronal and sagittal T2 fat SAT image, we can see the FOP zones correlated with the sagittal T1. The starburst pattern of edema extending into both metaphysis and epiphysis is a characteristic feature, and we have to be careful, not to confuse with a bone bridge. In case of overuse injuries, we can see in this MRI the physis, the thickening of the physis, the cartilage cells not only become more active in this case, but also apparently more prone to injury, possibly as a result of thickening of the hypertrophic zone of cartilage. On MRI, we can see in the posterior aspect of the tibia, and 2 months later, when the patient is staying out of activity, the healing of the growth plates. Another patient with a stress injury in distal femur, we can see here that a chronic physical stress injury shows a higher incidence of zone of provisional calcification discontinuity and focal physical thickening compared with Salter-Harris fracture, reflecting disruption, as we see here, in normal endochondral ossification. A recent publication report that this finding can overlap in two groups, but in chronic stress injury, no periosteal injury, no soft tissue edema, and no showy fusion. And those features, yes, we can see in Salter-Harris fracture. In our country, soccer is a very popular game, so many children start to play it at very early ages, and we usually see this kind of alteration. In Perthes disease, sorry, I have a problem here. Well, Perthes disease, we have femoral head osteonecrosis, which occurs secondary to the abnormal blood supply. Epiphyseal vascular compromise leads to injury of the epiphyseal and juxtaepiphyseal growth plates, producing a spectrum of finding. In general, the initial test for diagnosis is a pelvic radiograph, and change depends on the severity and length of the alteration. We can see in early stages maybe no appreciable change, in established disease reduction in epiphysis size and lucency, and in the late disease fragmentation, destruction of the femoral head. Conventional MRI has been shown to better delineate the extent of epiphyseal involvement than plain radiography, and different modality of MRI, as Dr. Tekla explained very well, such as perfusion and diffusion, delayed gadolinium enhanced MRI, and dynamic gadolinium enhancement subtraction, may offer new insights into the pathophysiologic prognosis of the disorder. In this is a patient, 10-year-old, with a history of intermittent right hip pain for 2 months. The AP radiograph, we see that the right femoral head is in the initial stage of Perthes disease, will increase radiodensity, but without any fragmentation. The T1 image shows decreased signal in the superior region of the femoral head, and in C, with contrast-enhanced subtraction image, we can see that the most of the epiphysis is lacking contrast enhancement due to the hypoperfusion. In case of this disease, blount disease is a local disturbance of growth of the medial aspect of the proximal tibial metaphysis that results in tibia vara. The condition is commonly bilateral. These are 3 subtypes: infantile, juvenile, and adolescent. The infantile type is a lot more frequent, and it's seen particularly in early walker. In conventional radiograph, we can see the big-like protuberance of the medial plateau on the left side in this case. The diagnosis is important because untreated blunt disease is associated with a poor prognosis, especially in young children. And on MRI, we have to visualize the cartilage and the meniscus. Well, as a regard as endocrinal issue, I want to show you scurvy. It is produced by vitamin C deficiency. On this radiograph, we can see generalized demineralization and cortical thinning. The Frenkel line, this is the Frenkel line, is a dense zone of provisional calcification, and the Trumanfeld zone, it's a loosened metaphyseal band underlying the Frenkel line. We can see 2 metaphyseal spurs that result in capping of the metaphysis due to healing of microfractures called Pelman spur. In MRI, the appearance of scurvy is an abnormal low T1 and high T2 in the metaphysis in this coronal T1 sequence is likely due to normal marrow components being replaced by hyaluronic acid and water. And additionally, periosteal reaction due to superiosteal hemorrhage is the key feature of scurvy. Rickets, this is another indirect lesions. It's an endocrinal issue. It's a cartilage growth plate disorder caused by insufficient mineralization due to deficiency of calcium, phosphate, vitamin D, or other cofactor. The onset and presentation depend on the etiology and degree of deficiency. Typically, in severe cases, rickets become apparent in the second year of life with genu varo, like in this patient. In this disease, the hypertrophic chondrocytes do not go under apoptosis, and the cartilage tissue increases, the growth plate thickens, and the ends of the long bones, especially weight-bearing bones, deteriorate, resulting in rachitic deformities. The capping is the concavity of the metaphysis and widening of the metaphyseal ends. On this MRI, look, we can see it's a patient with X-linked hypophosphatemic rickets. In A, the dotted line shows the widest portion of the physis. In C, we can see the normal pattern of the zone of provisional calcification to compare with A and B. In D and in E, we see the bone marrow abnormalities of the epiphysis. In G, non-pathological heterogeneous signal due to normal conversion. And in H, we can see the Harris line, a thin transverse metaphyseal lines appearing hypointense in all sequences. As indirect lesions, these patients develop physeal growth-related complication after epiphysiodesis due to genu varo. We can see on radiograph bone marrow lucency with angulation in left femur and tibia, and on MRI we can see the physeal tongue in the anterior aspect of the femur. This is another patient with a physeal tongue in the medial aspect of the femur too. This physeal tongue have a distinctive appearance on MRI with what appears to be a distorted partial translation of the physis that extend into the metaphysis, and bone marrow edema can surround physeal tongue. Another mechanism of lesion is osteomyelitis. In this case, transphyseal hematogenous osteomyelitis is a serious condition that can affect the growing physis. Pyogenic infection have MRI finding of transphyseal spread, as we can see in this 14-year-old with an alteration of the bone marrow with surrounding edema in the growing physis. The follow-up in these cases is important to detect bone breach, as on this coronal T1 and T2 fat SAT, when we can see a large central tibial physeal breach. In this coronal, T1 show high signal intensity breach that is so intense with fatty marrow. Radiation at the end of a growing long bone has been shown to produce distinctive changes near the epiphyseal plate, only see when epiphyseal plate is included in the treatment field. In this 12-year-old boy with synovial sarcoma, we can see the thickness in the left femur and proximal tibia, and in this girl with epiphyseal widening and the metaphyseal sclerosis and frying on her wrist, then the radiotherapy. And the last point is the imaging in the leukemia process. Leukemia itself can already have an adverse effect on bone at diagnosis. In most children, we can see abnormalities just as juxtametaphyseal lucens, bands, and lytic lesions in wrist and in the elbow. And we can see on MRI in T1, in this case, diffuse replacement of the normal bone marrow signal intensity. In these cases, it is important to be sure about the age of the patient and to know the normal bone marrow conversion. So, summarize, the physis is a highly specialized structure, allows longitudinal long bone growth, and is susceptible to direct and indirect injuries. Thank you very much for your attention. I share with you, this is the Garrahan Hospital in Buenos Aires and Gandulfo Hospital, and this is the radiology team.
Thank you very much, Dr. Anoni, for this fantastic overview and for sharing your experience on physical acceleration. I can't see any question in the chat, so I just ask you a recommendation for the audience. Can you tell us which is the optimal protocol for physical evaluation, or we could say which sequences are mandatory for physical evaluation in your experience?
I think the sequences are mandatory T1 to evaluate the bone marrow, and then you need to assess some sequence FAT-SAT, perhaps as a STIR or T2 FAT-SAT to look for edema. But I think in children, it's very important to know the history about and the age. The age is crucial to can evaluate the bone marrow.
Yes, I totally agree. The age is the most important thing.
And when you are not sure about the color of the bone marrow, you have to compare with another patient the same age, try to look for another MRI to compare the color of the bone marrow.
Thank you very much, Clara. I don't know if Sebastian wants to conclude or say something.
So yeah, thank you again, Clara and Tekla, for your wonderful talks. Just a reminder, as we wrap up, I would like to remind everyone that if you would like to receive a certificate of attendance, you can email the WFPI website. The details are already shared in the chat. Please note that there is no CME or CPD accreditation for this webinar, but you will get a certificate of attendance. Again, thank you all for attending, and thanks to our speakers for this wonderful meeting.
Thank you very much, everyone.
Bye-bye. Thank you very much.
Thanks for our great speakers and our lovely moderators. All the best, everybody.
Thank you, Mary.